want to take this opportunity, ladies and gentlemen and distinguished delegates, to warmly welcome you to this segment of our side event, where we're going to be discussing a very thematic issue and a contemporary issue in the health of our adolescents and young people and towards the country's response to end the HIV and AIDS epidemic. My name is Douglas Bosire. I'm the acting CEO for the National Syndemic Disease Control Council. I'm going to be a panelist, so I'm not going to talk much, but I'm going to invite the representative of the chair of the council just to come and welcome all of you so that we can proceed and take advantage of the time that God has given us this morning. So I want to welcome Director Tom Okundi to come and give us his remarks.
His Excellency Wesley Rotich, Governor Elgeyo Marakwet, other Excellency Governors present, honorable members of Senate, National Assembly and the County Assemblies, County Executive Committee members, County Chief Officers and other county government officials present, board members of the National Syndemic Diseases Control Council, the Acting CEO, National Syndemic Diseases Control Council, and other CEOs and Directors Generals present, esteemed panelists of the day, colleagues from the national and county governments, counties, communities of people living with HIV, our adolescent and young people, ladies and gentlemen, good morning. It is my honor and privilege to join you today in Homa Bay County for this event on the sidelines of the auspicious 9th Devolution Conference, which introduces the board. I wish to introduce the board members present. If they could just stand and wave. I stand here as a director representing the chair who is unable to be with us. Good morning once more. Distinguished delegates, counties continue to be cornerstone for promoting and securing the health of Kenyan people, supported by the national government in accordance with the 4th schedule of the Constitution of Kenya. Over the last 13 years, tremendous progress has been made across all 47 counties, which are our devolved units in HIV response and other syndemic diseases. Over the same period, the NSDCC has continued to forge close collaboration, cooperation, and consultation with the county governments to keep the journey towards ending the public health threats posed by HIV and other syndemic diseases on course, an undertaking that has registered a great degree of success. For the next 2 hours, we will have a discourse on how to end the triple threat and a critical county priority of ending new HIV infections, pregnancies, and sexual and gender-based violence among adolescents and youth, which threatens the gains and the collective results that we have made. On behalf of the National Syndemic Diseases Control Council, I assure you of our resolute commitment to continue our partnership with all county governments, development and implementation partners, communities of people living with HIV and AIDS, survivors, adolescents, and young people, and all stakeholders in this noble goal. Ladies and gentlemen, let us have this conference. Let us leave this conference with renewed vigor, re-energized passion, and rekindled urgency to account for the health, dignity, and future of adolescents and young people. It is now my pleasure to invite one of our foremost advocates of this initiative, Honorable His Excellency Wesley Rotich, the Governor of the breathtaking County of Champions, Elgeyo Marakwet, to give us a keynote address to contextualize our dialogue today. Thank you for your continued support, and may God bless all of you. Thank you.
Asante sana. A round of applause for the governor as he takes over. 10 minutes for.
Thank you. Let's clap for our chair. Thank you very much. The chairman, my colleague Governor Sang, and the MPs who are here, all county government officials, all our partners, the CEO of NSDCC, youth champions, policy influencers, invited guests, ladies and gentlemen. I will read a very brief speech. It is both a duty and an honor to join you today as we pool our ideas, discuss solutions, and develop integrated, sustainable approaches to addressing the triple threat facing Kenyan adolescents, namely pregnancies, new HIV infections, and sexual and gender-based violence. I stand before you today not only as the governor of Elgeyo Marakwet, but as one of you. I also speak on behalf of my colleagues at the Council of Governors and partners in the government to express our profound concern over the growing challenge of triple threat, new HIV infections, adolescent pregnancies, and sexual and gender-based violence. These are not abstract statistics. They represent the lived realities of our children, our families, and our community. We therefore gather here united by shared commitment to protect the well-being of our adolescents and secure the future of our nation. I wish to sincerely thank the NSDCC, National Syndemic Disease Control Council, for inviting us to be part of this dialogue. My hope is we leave this forum practical, actionable, with practical and actionable takeaways that will inform continued efforts against these threats. Allow me also to appreciate the council for partnering with my county to host the first ever regional Men and Boys Summit, which was done last month at Tambach TTC in Elgeyo Marakwet County, which brought together representatives from 7 counties to address HIV/AIDS, mental health, gender-based violence, gender equality, and drug abuse. In Elgeyo Marakwet County, we have embraced the engagement of men and boys as agents of change through our traditional Kokwa Boy Mentorship Forum, where men guide boys in cultivating positive societal and champion efforts to address the triple threat. The impact of triple threat in counties. The triple threat of new HIV infections, adolescent pregnancies, or I can say to shorten up the triple threat, remain a significant health challenge for adolescent and young people in Kenya. In our country, for example, the situation every week, we record an estimated 54 new HIV infections among adolescents of 10 to 19, alongside 4,633 adolescent pregnancies and 334 reported cases of sexual and gender-based violence. That is per week. While this is a national challenge, it is one that reveals stark disparities at our subnational level. These figures are clear call for urgent accelerated action. Adolescent pregnancies disrupt education, limit economic opportunities, and negatively affect health and socioeconomic development indicators. The triple threat impact in our counties is deeply damaging. Mistimed pregnancies force girls out of school, trapping families in cycles of poverty, rising new HIV infections among our youth, place immense strain on already limited health budgets. Therefore, we cannot afford to address these separate challenges. They are interconnected, each feeding into the other, and therefore, they undermine our county's capacity to grow and prosper. In Elgeyo Marakwet, we have witnessed these challenges firsthand. However, we have also demonstrated that with strong political leadership, coordinated partnerships, and culturally sensitive strategies, it is possible to reverse these trends and safeguard the future of our young people. Devolution has been a game changer for adolescent health. It has brought decision-making, resources, accountability closer to the people. We have embraced this responsibility fully, placing adolescents' health well-being at the center of our development agenda. We have had few strategies in Elgeyo Marakwet County, namely community and cultural engagement. We have been having boys to men mentorship programs. Even as we speak today, when we had the school holidays, we have been running across the county. Second is the government and leadership action. We have strengthened our Ngao partnership through NSDCC. We had a meeting with all our chiefs and assistant chiefs and village elders, and we had a lot of programs that we are supporting together. We're also partnering with role models. We bring influencers, social influencers, and even digital male athletes in my county, because we also have gender-based violence by athletes, and we have brought them together. Fourth, Service delivery improvements, establishment of gender desks in our police station has also been another strategy. And fifth strategy that we have applied in my county is awareness and community outreach, hosting youth fun days as dynamic platforms. When I came in 2022, I started a very big tournament called Governor Waraya. We didn't have triple threat program that time, but this year we played 200 teams that time. This year, beginning next week, we are playing 650 teams from the grassroots, and our theme this time is ending triple threat at the grassroots level, to have the young boys to help us. Barriers and gaps to interventions in my county include security and cultural challenges. You know, in Elgeyo Marakwet, we still have FGM. We still have insecurity. This hamper our program. I know it can be in other counties is different. Secondly, adolescent vulnerabilities, including poverty, early pregnancies, and increased exposure. My research, and because I'm an economist, my simple research shows that poverty has company. When children are poor, come from poor background, they are more vulnerable to all these three. A child of an empowered mother cannot be assaulted. A child of an empowered mother cannot be forced to FGM. But a child of a poor mother, because she has no one in the community, she always begging. When a daughter is picked to be taken for FGM, she has no choice. She has to accept, because this is the only community who will take care of me tomorrow. But an empowered mother, an empowered family will never accept to be in this. Somehow, there is a way wealth can protect your children. But when you are poor, it means your children are even equally easily manipulated, including children who are called along the road and being told, come, I'll give you sweet, by border riders. So when your child has never seen sweets, bread, all those things, she will be running for those things. Poverty is the enemy. We fix poverty, we fix majority of these problems in triple threat. We also have limited health system limitations, inadequate human resource at our health system. Call to action. Colleagues, addressing the triple threat requires political will, sustained financing, community ownership, and united front. This is a promise of devolution, that every county can design and deliver solutions that protect its people, especially its youth. And this will include the following: invest consistently in adolescent health, not as a side project, but as a foundation for development. Secondly, stand united in our rejection of harmful cultural practices. We have all to stand united against this thing. If it's FGM, we have to say no to it. All these challenges, we have to say no to it. Ensure survivors of GBV receive justice, not kangaroo court settlements. That is our biggest problem, especially in my county, where still people talk. When they have land disputes, they still talk. Sexual harassment, how do you talk with someone who has defiled a 10-year-old? And you say we are discussing and something will be given to old men? That is madness. In my county, I have said, when you get you molesting a child, when you get you in those, you are supposed to be taken to the police station. And as you are being taken to the police station, you are being greeted. If you get there alive, thank God. If you don't, we say hallelujah. That has made sure in my county now, there were used to be so many cases of people defiling 3-year-olds, 2-year-olds, 4-year fathers defiling their daughters. That has never happened in the last 1 year since I threatened people. So sometimes you can even use crude ways, and I have used those crude ways. And you know, in my county, when you threaten someone like that, they know it's not a joke. I know what you know what I mean. Invest in youth empowerment. What we need to do, the reason why some of these youth are in this situation is because of drug abuse and because of idleness. And the same thing I said, poverty is the problem. We fix the poverty, our families to have it. What I'm doing in my county, I'm forcing every family to have something called cash crop. That means the families will be employing themselves, and it's labor-based, labor intensive. For example, pyrethrum is labor intensive. A family employs all its children weekend, and they do so. So idleness reduces, they have money, you fix poverty, at least there is a lot of time for some of these bad habits. Finally, as a county, we reaffirm our commitment. As governors, we must lead from the front, ensuring no adolescent and young persons are left behind in our march towards healthier, safer, more equitable Kenya. In conclusion, let us all remain committed to ending triple threat, protecting our young people, and creating a society where every adolescent can thrive in health, safety, and dignity. This is not just a fight for health, it is a fight for the future of every county in Kenya. Let's win together. As I finish, I want to thank you and thank NSDCC for the good job you've been doing together. I will continue being your champion at the Council of Governors, and partly because I'm a young person and I have seen the challenges that our young people are going through. Let us all harness our resources, and if possible, we make this a mainstreamed issue across our sectors. When you are having public participation, there should be someone at the county level mentioning this triple threat. When you're having a chief's barasa, someone should be doing it. We are planning something with the NSDCC to have all our religious leaders come to a forum like this so that we guide them again and train them. So after a sermon, they announce and say there is something called triple threat. We need to have grassroots champions, not only boardroom champions. It's not, we need to have people at the village level who will support us in this campaign to ensure that we succeed. And when we succeed in this campaign, we will be able to manage. And therefore, the other danger that we will face is that the current generation has a lot of carefree and a lot of information online. They want to experiment so many things, and they have a lot of carefree life. Therefore, it's the responsibility of us as parents and of us as leaders to ensure that we guide our young people to the right path. Thank you so much, and God bless you. And receive greetings from the County of Champions.
Thank you very, very much. Where's a round of applause for His Excellency Wesley Rotich, the Governor for Elgeyo Marakwet, for that very, very comprehensive analysis, plus the radical moves that you've made to ensure the triple threat is dealt with. As you've heard from him, if you defile a child as you walk through the police station, unasalimiwa. I'm sure we all know what that means. All right. So without any further ado, we're going to have the next 1 hour, and this is going to be a panel session. 30 minutes for the panel and 30 minutes for you, because we've all agreed that we have to fight the triple threat together. We all have ideas of how to deal with this. If you're wondering what the triple threat is, we're about to explain it to you. So let me call upon my panelists. Each and every one of them will have just about 4 minutes to make their remarks, and then I'll open the floor for questions and reactions. And we make this a very interactive session, all right? Over the next 1 hour only. Let me start by calling upon Douglas Bosire, the acting CEO, NSDCC, National Syndemic Disease Control Council. Kindly take the first seat up there. He will be speaking to us about the strategic direction and county coordination of the HIV and AIDS syndemic disease response. Let me call upon Shalon. Yes, it's Shalon. Shalon Watiri. She's a peer educator. Thank you very much for making time, Shalon. She's the voice of the youth. She'll speak to us about her lived experience and the demands for leadership. Kindly take the next seat. Let me call upon Jacinta Achieng. Jacinta Achieng is a parent. A round of applause for her. She comes up. She will speak to us from the family level perspective on adolescent vulnerability and community accountability. Let me call upon Senator Catherine Moyeka Moma. Senator, thank you very much for making time. Senator will speak to us about the parliamentary leadership in legislation, equity, and social justice. Let me call upon Dr. Mohamed A. Sheikh, Director General, NCPD. Thank you very much for making time. He'll speak to us about the demographic strategy, youth programming, and development. Let me call upon Brian Retman. Brian Retman is the PEPFAR Country Director. Asante sana for making time. He'll speak to us about navigating the global financing landscape. Dr. Samuel Kinyanjui, Country Program Director, AHF. A round of applause for him as he comes up. He'll speak to us about the Global Health Partnership and Integration for Sustainability. And then let me call upon Trevor Umbija. He's the moderator. He'll do the most important part, waiting to serve lunch. Thank you very much for making time. And then, as we have agreed, I will give you a chance, 30 minutes each, to also give us a conversation from your perspective. Not everyone will get 30 minutes. The audience will get 30 minutes. My panelists will also get about 21 minutes. Every one of them will speak for just 4 minutes, okay? As many as of that opinion say aye, the ayes have it. There's no contrary opinion. Thank you for making time. All right, so I'll start with you, Dwosire. And let's just get straight into it. We are talking about the triple threat. What is the triple threat?
We had 58,000 cases of AIDS-related deaths. In the year 2024, we had 21,007 AIDS-related deaths. In the year 2013, 2013, at the advent of devolution, 2013, we had mothers transmitting HIV to their children. Out of every 100 mothers who were HIV positive, 21 were transmitting the virus to their children. So we really commend the county governments for this effort, and together we see that it is possible to end AIDS as a public health threat. However, when we look at the subpopulations, when we look at the trends and the dynamics, we realize that there is a particular concern that we have of rising cases of disproportionately higher infection rates than other population cohorts. For example, in the year 2024, 41% of all the new HIV infections, which I've mentioned earlier, occurred among adolescents and young people aged between 15 and 24. In that same year, if you take your calculators, you will realize that 240,915 who are the children aged between 10 and 19 who presented with pregnancy in our health facilities across the country. 240,915. Per day, that translates to 660, ladies and gentlemen and distinguished delegates. So 660 children between 10 and 19 were presenting with pregnancy in our health facilities per day in Kenya. So we realize that this is not acceptable, and these trends, if they continue, then they threaten the progress towards ending AIDS as a public health threat.
Right.
And the definition of the word a threat is a phenomenon or an occurrence or an act that impedes or poses a risk to our collective journey towards attainment of certain objectives and goals. That is why in the year 2021, we decided to break down our silos, because we realized National Council for Population and Development as the agenda and the mandate of ending adolescent pregnancies by the year 2030.
All right.
NSDCC has the mandate of ending HIV in the country by the year 2030. The State Department of Gender has the mandate of ending all forms of GBV, including SGBV. So we said these are related syndemics. If you get a pregnant girl, it means that pregnant girl was predisposed to HIV infections. If you get a girl who has been defiled, that means this girl also suffers a higher risk of HIV infections or adolescent pregnancies. Okay. So we say, let us break silos, let us come together with the county governments, let us come together with the development partners and implementing partners, so that we can have what we call a whole of society, broad-based multi-sectoral approach and discussion towards addressing the drivers, then end this triple threat,
and
as we call it.
Dr. Busire, you've mentioned the county intervention levels. What are some of the policy shifts that you think needs to be put in place between county and national government so that we deal with the triple threat effectively at county level?
Thank you. The attention that we should pay if we are to end HIV as a public health threat and these triple threats collectively is forging multi-sectoral approaches that bring all stakeholders on board. New HIV infections, for example, do not take place at the health facilities. They take place in the sugarcane plantations of Ndiwa, where you have sugarcane cutters who come from all over the country, mobile workers population. They defile young people there, they give them pregnancy, they give them the virus, and go back to their home counties. These new HIV infections occur when the fishermen here of the lake decide that in the morning before they sell to the women who are going to sell the fish in the market, that woman must undress and have sex with him so that they can get their daily bread. So we must bring all the stakeholders and the actors together. That border that Governor talked about, and there is an advantage. There is an opportunity that now is in the counties. Okay. All the counties have passed what we call the Facility Improvement Fund. These are funds that are collected by the facility, both from on-source revenue, from the payment they receive, and also from the share reimbursements. Okay. Those funds are in-phased within the facility that collects them or receives them. Okay. A fraction of those funds can be used for prevention activities within the community to avoid the workload, the enhanced pressure that the facility is under when the infections continue proliferating in the community. Okay,
thank you. We'll come back to you if time allows, but let me hear what Shalon has to say about this. Shalon, tell us your story.
First of all, as you can see, I am a community health promoter, the youngest in Nyeri County. So the challenges that we face is stigma and judgment from the healthcare providers, people who are the community people, and everybody at large. Because now what I would want us to do is please, and I say again, please, let's not shame people, because when I'm going at the health facility to go and get my ARVs, or even because I'm a girl, I also need the family planning. Don't stay there as a as a doctor, a healthcare provider, and start judging me from who you are seeing, but not understanding me, the journey that I'm going through.
Yes. How can you be involved better to deal with policies that will then deal with the triple threat? Do you want barazas? Do you want to be called to meetings? How can that work?
I can be involved better, not only to go and sign the participant list. No, I want to be at the table. When implementing, while discussing, implementing, and also budgeting. Acha nikue hapo. Wacha maoni yangu yasikike. Si kuandikwa tu. I want to be involved as a young person.
And what have you seen as progress so far right now? Unaweza sema utaki tu kukaa hapo na kuandika kujaza jina. Is that what happens? Mnajaza tu jina and then your ideas are not taken into account at county levels?
We are not yet there.
Okay.
But we are trying. Now, I don't want the next time the other person who is coming to present the youth won't say that we are trying. No, actually, the person will say we are doing, because we will be actively involved in these policies. We'll be actively involved even in the politics and everywhere. We have the skills. We have everything. The only thing is you are not utilizing us to the fullest.
All right. Thank you, Shalon. Very well presented. Let me bring in Jacinta now. Jacinta Ching is a parent there. What kind of support do you think parents require, and the young children as well, who you deal with?
Thank you very much. I believe if parents get access to good information and open communication, will be a better place to have forums where parents and children will be able to air their views. And through these communications and information giving, the parents will be equipped well enough to handle their youths at early stages and also during their upbringing at early stages, I mean. When these communication open forums are well enhanced, I also believe that the adolescents themselves will be able to express themselves freely, share their ideas, and in return, get that blame game thrown away out of their lives. They'll be able to equip to reduce being vulnerable and getting closer to getting infections and pregnancies.
Yeah, Jacinta, the interesting thing is that mostly people blame parents when such events happen. What role do you think the parents should play when it comes to dealing with these issues around triple threat?
The parent in the first place should be there for their kids. When the parents are away, we find the kids become so much vulnerable. So parents need to take time with their children. They don't need to give up. They have to be there for their children. Charity begins at home. You don't expect somebody from outside to come and train your child. As a parent, you should be there for your child. So taking responsibility as a parent is very key in the life of a kid.
Jacinta, have we gotten to a point where parents can freely talk to their children about the challenges like triple threat? Can you openly sit with your daughter and tell them that this is what you should and you should not do, and if this happens to you, you're open to come back home? Because we still see the stigma where people say, especially from the Luo Nyanza region, once you go and you're married, meaning you've gone there, you're not supposed to come back, no matter what happens.
Well, this communication between parents and kids is very, very, very important. Like in my situation, I'm an experienced parent. I want to give you a short story of what happened to my daughter who got pregnant at the age of 13 years. She happened to have felt vulnerable or maybe succumbed to peer pressure and got pregnant while I was away. I was an upset parent. So this is my call to all those parents to be available for their children. So we find that in a scenario where parents are able to share with their children closely, so many things are avoided. And I want to tell you that this thing is practical. Actually, in the municipality where I come from, within the municipality, there is a collaboration with Kobonef. We have KMET as organization and the municipality of Ndiwa, and they're trying to revive a traditional model of dialogue that is called Dual and Siwinde. And this thing is practical, it's working. You know, if I go maybe back again, the Siwinde was a sacred place. That is for the Luos. If maybe you are getting lost, the Siwinde was a sacred sitting session for female and male, where the old grannies would come up together and share wisdom with their young grandies. And the dual was sacred for male and young men, the elderly males and young males. So through this kind of setup, behavior change was cognitive during early days. So my municipality is trying to reimagine this and restructure it back at the moment. And I believe it's going to be result-oriented.
All right.
I think NSDCC, as a coordinator on issues of HIV initially as NAC, and now on syndemic diseases, has done an excellent job in bringing out the issue of triple threat, which in my view, Trevor, is possibly the greatest danger to our future. But you will hardly hear politicians speak about it, especially male politicians. It seems as if GBV, HIV, and teen pregnancies is business for women most of the time. So I actually want to commend Governor Rotich for being a champion and for realizing that actually we bring our communities down by not focusing on this issue. And my take is that it's not so much for lack of policy as it is for lack of recognition of the importance of this issue and lack of strategies to implement on this issue. You've just asked, I forget her name, Jacinta, yeah. A very good question as to whether parents can really speak to their children
freely.
The truth is that the matter of sex is a taboo conversation. Our parents didn't discuss with us. We find it very difficult to discuss with our children. And we have, policy-wise nationally, we've even stopped. Sex education is prohibited in the schools. So we have prohibited sex education so that nobody else, I can't speak to my child because my Luo or Luya tradition never taught me how to discuss sex with my child. It was supposed to be a grandmother or an auntie. The school system has said no. The school cannot be the space where you can discuss this issue. But the policy on the internet has opened the internet. So this child can actually go to a porn site and be taught anything around sex. Yeah. If you Google if you write sex on the internet, it is unlikely to bring you sex education, what you should do at age 13. It is likely to bring you maybe porn sites. Are we worrying about that? Nobody's worrying about that. So my view is that nationally, we need to rethink and know that because we have blocked the opportunity to discuss about sex, to discuss about the consequences of casual sex, both for boys and girls, because it's not just girls. Girls will get pregnant. The boys will also, you may get STIs for both boys and girls. You may get HIV. Yeah. The boys might think they can't get pregnant, but I don't know anybody who likes to be a father at 13 because there is nothing you can do for that child that you are fathering. So we need to rethink what we are doing. Secondly, it's a multi-sectoral issue. Teen pregnancy is in fact the wrong name. It is defilement. Trevor, when you have a 10-year-old pregnant child, that is defilement. It's not teen pregnancy. So the question is, when there is defilement, what does the law say we should do? Where is ODPP? Who is in charge of the police? Who should be arresting? Who is in charge of the chiefs? So, Honorable C.S. Murkomen is as much. has an interest in how to deal with the triple threat, as is the Minister for Education, the CS for Education, as is the CS for Health, as the CS for Culture and Gender. So we need to get back to find out, when the CHP tells you that we have 3 families with 13-year-olds who are pregnant, what does the chief do about it?
Okay.
Does the chief get elders to negotiate so that you commit the next crime, put that child into child marriage, another crime? What are we doing? We are not implementing the laws that are there.
Yeah.
We have treated this as a woman's issue. And in society, when you treat it as a woman's issue, it can wait.
Okay.
But when it is everybody's issue, you can do something about it. Allow me.
Yes, and then I'd like to hear what the Senate intervention would be to ensure that counties have adequate funding. Because you are in a role of responsibility. Unlike all of them here, you can actually do something.
Absolutely. Now, is it funding? The question is, like I've just told you, it's not about funding. But on funding, you will be aware that Senate is always, every year, we are always fighting for greater allocation
to the counties.
But we are also...
do they allocate more money to fighting triple threat, or they go into their...
Now, you see, once it is allocated,
yes,
the counties now have the latitude to actually divide what they get into health, into their functions.
Yeah.
And the county assemblies need to know that is their first responsibility to oversight. So the question we should be asking, to what extent are our county assemblies ensuring that enough money is put towards the issue of triple threat?
Okay. Yeah. I'll come back to you in just a bit, but let me bring in Sheikh on this. Dr. Mohammed Sheikh here, Director General, NCPD. You know, how can we utilize population data?
Thank you, Trevor. First and foremost, I want to take this opportunity to thank the National Syndemic Disease Control Council for really organizing this side event. I know we started this event, this program together. Initially, it was a disjoint program where we're dealing with teenage pregnancy as an issue on one side, gender-based violence on one side, and again, HIV on the other side. I think we came with this theme of ending triple threat, I think in the year 2020, during the COVID outbreak. It's very important always to have data. If you look at our population currently, over 75% of our population is below the age of 35 years. Over 25% are below the age, or 26% are below the age of 25 years. And over 20% are among those who are calling them adolescent, between the age of 10 to 19 years. This is an age group that's really, that requires quality education, that requires good health, that requires other supports. But also they face a lot of risk. The risk of gender-based violence, HIV, early marriage, female genital mutilation. So it's important that these counties have the right data. And I think during the census, that's in fact the cohort that we consider, and also during the Kenya Demographic Health Survey. It's important to have this data because you need to do the right investment. So you don't plan, but you plan based on the geographical locations, on their socioeconomic status, and the needs and the challenges, so that you just don't put money where it's not necessary. You also require data for monitoring and evaluation, so that at least you can see the success of your programs. You can also use the data, the same data, also to do advocacy and public education, as Senator has talked about here. Sometimes we talk about, we just argue a case without presenting the right information to the policymakers. But we want to give them the right data, the number of girls who get pregnant every year, the number of girls who drop out of schools, the number of girls who undergo female genital mutilation, and among them those also undergo gender-based violence, and the number with HIV infections. Without the data, then you can make the right investment, the right monitoring, and do the proper advocacy. On the same, Trevor, I'm sure you will also ask me that, why we are focusing on issues of triple threat, it is the economic cost, the economic loss, and the burden to our city, to our country. Imagine the girl at the age of 10, or that adolescent at the age of 15 years who drops out of school because of pregnancy. First, she will not get the right career. Second, she will not also achieve her full potential as she grows. So in one way or the other, every year, more than 300,000 girls pregnant in our country and below the age of 18 years. Just multiply that number on the laws on that one specific girl. And that's why the reason we're saying for us to harness our demographic dividend, for us to achieve our, our aspirations and goals as a nation, we must address the issue of teenage pregnancy because we are losing a big chunk of our population who could have contributed to our country. And that's why we're saying issue of teenage pregnancy, gender-based violence, and HIV should be taken to another level. And really, I commend the National Syndemic Control and the governor and the senator really who have come out for this program because we feel sometimes, we are the only one who are struggling.
Yeah.
So, but when I see this kind of team here, I always feel very happy.
What strategies can now counties adopt to deal with the triple threat at a time when donor funding is shifting and increasingly becoming smaller with time?
And I think that last piece is important because let's not say shifting, it's reducing.
Yeah.
Well, let's be plain. Donor funding is reducing. Mm-hmm. And the other reality is that there is a mindset that has been in place for as long as we've been here, for as long as Kenya has been in place, that the donors are going to take care of it. Whether it's HIV, GBV, or a teenage pregnancy, the donors are going to take care of it. And I think there's been a little bit of silver lining over the last 8 months, has been a little bit of change in mindset, at least in the papers, to say, we should be taking care of this ourselves. And I'm happy with that. I'm positive about that. And there's a really short answer to how do we get funding to come into place, and that is we put the funding in place in the budget and we actually realize that budget. And I think the challenge is that sometimes Treasury has put things in the budget with the full intention that they're never actually going to realize it because they've put it in there to appease one of the other donors to say that oh yeah, we're covering it. And the reality is it needs to come in place. And that's both at the national level and at the county level. When we look at PEPFAR, we have two big funding buckets. One is on commodities and the other is on people, the human resources for health that we have in counties. The people is when we look at the glide path for PEPFAR and the transition of PEPFAR, those people are going to have to get covered from county budgets. The commodities is going to get covered from the national budget or other sources. And so I think really getting realistic in what that looks like and saying what we are going to do is important. The second thing is actually prioritizing health and the social services that are around this is really going to be critical. And the reality is Kenya can do this. Kenya is moving forward as middle income country. They can do this. It's just a matter of ensuring that prioritization is really taking place, understanding what the glide path will be so that we're not just springing things on you like what happened 6 months ago. Mm-hmm. And that we are actually saying, okay, this is how we can do it, working with you really closely to say how we can get there.
Yeah.
But it, again, needs to be prioritized, and that response needs to be done in an integrated way that is really changing the way that we're doing the dynamic in country and changing the response. And we've seen some really good examples in the last 6 months. Some challenging examples as well, which I know he's going to talk about, in terms of in counties that, because of the stop work orders, they took on an integrated response that in some places were really good. And what we need to do is learn from those places that we're doing really good and be able to broadcast that out to other counties. And the places that did not do as well, learn from those as well and move forward and try to have that.
So you're saying that this has to start from the budgeting point, because I've seen budgets that include donor funding. So they should almost be like a supplement rather than an actual budget line, because it's not coming. Nobody's coming to save us. Is that what you're saying?
I think it needs to be a true budget line, because when we've seen it as a supplement, again, doesn't usually get realized. So a true budget line that says this is what we're doing, but that budget line doesn't have to say HIV. It can be health that's in an integrated way, because the reality is when a patient comes to services, they're not coming as HIV. They're not coming in that silo. They're coming as, here are the things that are wrong with me, XYZ. And the doctor needs to be able to see them for all those things in one way and do it in an integrated way so that those patient services are really integrated.
All right. Let me bring in Dr. Samuel Kinyanjui on this. He's the Country Program Director, AHF. And Dr. Kinyanjui, how can development partners align their support to strengthen the localized efforts of fighting triple threat?
So thank you very much for the question and the opportunity. And it's glad to speak after Brian and my other panelists have laid the ground. The donor funding is still coming, but it's clearly decreasing. And as a result, there are a number of things that as a country we can do, as counties they can be done, so that we increase the impact of the little that is still coming. And number one is aligning with the national guideline in terms of implementation. We make sure that our guidelines are revised and optimized. And when we talk about optimization, integration is critical because the siloed systems can no longer remain, they are unsustainable because each silo has both an administrative arm and an effective arm. And these many silos, all these administrative systems consume resources. The other thing is to really look for local interventions that work in our circumstances. What works in Los Angeles doesn't necessarily work in Kenya. And what works in here in Homa Bay may not work in Tiwi, in Kwale. So we also need, and that's where the beauty of devolution, because each county can be able to find a way and approaches that work in their own circumstances. The other thing is about using this funding, donor funding, as a catalyst, what we can call conditional granting, so that there are outcomes that are expected if the funding is continue coming. Then also the counties, we definitely as a country must take over this at some day. And that day I believe is now, is about using our local funding, domestic resource. And there are many ways to raise these domestic resources, not necessarily just depending on the one that is put as health budget. Because unfortunately, Brian and team, if it's put at health, it goes to Afya House. And the prioritization there is challenging. At the county level, the same. So when it comes to prioritization, I think earmarked funding is also another way to protect funding for certain sections of the health sector, not just putting it as health. We have the FIF funding, which are other ways of aligning, of getting this money. And one of the things that I personally think is an opportunity that is slipping away is social health insurance fund. If persons living with HIV and other chronic care were included explicitly, clearly, with clear that this is the package that they will get through NHIF, through social health insurance fund, a lot of us here are willing to put in money, including donor money. I strongly know that we are willing to do that, so that the persons who are living with HIV infection do not continue to be discriminated, isolated, and considered as others when counties are budgeting, when hospitals are planning their budgets and so on. Right. The other thing we can talk about is about joint and the other thing is about measuring outcome. Yeah. One of the biggest things that the siloed program that we call HIV response has done, and TB, is to show return on investment in real outcomes. Okay. The rest of the healthcare, and I'm saying this after 25 years in the health system, they don't measure outcomes. And as a result, it is difficult to show what they did with the money. And this is a big gain that's why we're saying bring in the other NCDs into the HIV organized system and platform, and we can show results for each. Okay. Finally, this is what I would like to say about that. Yep. I think we're talking to the choir here. There's a summit we were in on integration last year, and an important partner did not show up. This is the Ministry of Finance. I think we need to bring out this idea, not as a cost, but as an investment, so that the Ministry of Planning and Treasury, they sit through and see how this is an investment are not a cost.
All right. Briefly state your name and your question or comment to whoever you want to pose it to. Just your name, comment, or question. Thank you, sir.
Thank you very much for the opportunity. So my name, Efio Biero. I'm a registered nurse with the Chef Kenya at Rachonyo County Hospital. When you talk about triple threat, the HIV infection, the teenage pregnancies, as a nurse working at the comprehensive care unit dealing with adolescents living with HIV, I can say that at Rachonyo County Hospital, when you talk about viral load suppression, the suppression amongst adolescents is actually doing below the guideline. We are expected to have a 95% viral load suppression. Apparently, the older population we're having 98%, that is the adults, 25 and above. Between 10 to 24, we're actually having a below 90, that is 88%. And the pediatrics, the people who come with their parents, we're actually doing a 93%, which is good. As a nurse, where I sit, I've realized we need to have these adolescents and share with them the information about HIV. And as was said by the panelists, we cannot have this information in schools. These adolescents spend 90% of their times in schools where we cannot get them. But the Ministry of Education has barred us from giving this information. Whenever we go for school health, they have to give us the sticky notes, the side notes. Then we hear their complaint. So as a nurse, my request to the policy makers, well, we have the policies, but the implementation is where we have the problem. Can they give us an opportunity to meet these adolescents where we can have ample time with them, talk about the testing, talk about the pregnancies, and talk about the prevention? Thank you very much.
Yes.
Yes, that should be possible, but I know the Ministry of Education is under pressure because of the religious organizations. The Catholic Church, the other churches have always been against sex education in the mistaken belief that sex education will be about misteaching or teaching the wrong things, immoral things to our learners. Okay. I have said before in another podium, Kenya needs to decide what is this minimum pack we want to put in that curriculum. It can even be led by the bishops. Okay. I have no problem with that.
All right.
I'll talk of opportunities, and having listened to what our presenters did, I'm looking at the previously approved drug by the FDA, that is lenacapavir, a 6-month injectable prevention drug. Now, looking at our youth population, as a population probably of a huge number that are probably not HIV infected, can we have policy regulations on probably introducing lenacapavir at an early stage? Because this, if insured by, for instance, SHA, which is an expanding resource basket, this is on the backdrop of the fact that we are having shrinking donor funding. Is it possible that we have lenacapavir vaccination introduced through a policy directive which is sustainable to support our young populations and make it more affordable?
Thank you very much for the question about lenacapavir. For sure, the young people prefer PrEP more than other interventions to prevent themselves from getting HIV. Unfortunately, I cannot wholeheartedly endorse that for the following reason. Number one, it will always be like a recommendation for them to engage before their time. That's number one. Number two, the risk is that lenacapavir or any other PrEP method do not protect them from STIs, sexually transmitted infections. Neither will it protect them from untimed or teenage pregnancies. So for that level of cost, I think we can use those funding to for more effective interventions.
All right.
That's my short answer. Thank you.
All right, but Basiria has something to say. Yes.
Thank you very much. I would like to add on to what Dr. Kinyanjui has said. The least price for lenacapavir in the US right now is $28,000 US for 2 injections, a dose of 2 injections per year. $28,000 US is equivalent to about 3.6 million Kenya shillings. And because it is a patented molecule by Gilead, it will take the kind of interventions that we had in the 1990s when ARVs were not freely available to have that cost reduction. I know at the global level, as the African constituency and other constituencies which have a high burden of HIV, especially among young people, that is happening. But you can imagine the investment and the research that has gone on and convincing this business entity the need to reduce the price. It has to make reasonable business sense. So that is the challenge about mass administration of lenacapavir that I'm seeing that's going to be with us for quite a while. So let's now focus on what we can do. Of course, under the Global Fund, Kenya has been enlisted as an early adapter, but it will only benefit about 49,000 persons. And those people are going to be the key populations, the people at high risk, female sex workers, men who have sex with men, people who inject drugs, and other high risk populations. But the cost is still out of reach of many of these young people we are talking about. Thank you.
Okay, my name is Faith Ndungu, working for the Health NGOs Network. I have a few questions and I also have a few proposals. The first question is to Dr. Bosire around the framework around SHA and especially the Primary Health Fund. Do we have a costing for HIV interventions and what is the minimum package? Because even as we have advocacy, at times it's very difficult for us to introduce the HIV conversation because there's no costing. So that's the first question. Is it covered? Because you already know that you're already proposing FIF and bringing in the conversation around the Primary Healthcare Fund. Second question is around integration. What are the avenues that we are using to look at the person holistically? For example, when you're looking at a child who's living with HIV, immunization is a critical component. So are we working and anchoring around the primary healthcare structure, especially the PCNs, to advance the HIV services, but also to borrow from the lessons from the HIV sector, where we have, like Dr. Kinyanjui had mentioned, a lot of quality, a lot of there's a lot we can learn. How do we anchor that and bring it in the PCN space?
We have the Kenya population policy. And in that population policy, what we have prioritized, number one, are key population issues, and among them is the youth. Issue of teenage pregnancy, early marriage, gender-based violence are among in those policies. But the bill is totally different, just about anchoring NCPD in an act of parliament so that at least it can do some of this work that we are struggling to handle. Thank you.
All right,
I can just add, Trevor.
Yes.
We have laws that would deal with the issues of teen pregnancy, as I said. It's just that the health sector calls it teen pregnancy. That is defilement. It may be GBV. We have laws on those issues, so we need to, let's not make triple threat a catchphrase. Let us look at each of those issues and as communities decide that we are going to deal with this.
Okay.
In Nyakach community constituency, where I come from, that how are we going to deal with the 3,816 teen pregnancies we had in 2023? I don't think it requires a law. It's community to actually take on this issue.
Okay.
I do know that there are elements of care and treatment for people living with HIV which are not covered under the current package under the social health insurance scheme. So for that reason, as NSDCC and as and also our sister unit in the ministry, NASCOP, we are spearheading a conversation with the communities to come up with sound proposals of what is it that is missing, what must be included, including laboratory and the rest. And last week there was a meeting with the principal secretary regarding this, and the conversation is ongoing so that there can be a concrete proposal to the Health Benefits Advisory Committee that is reviewing that minimum package to make sure that people living with HIV's interests and needs are fully catered for. I know that's a conversation which is live, and it has to go on, and we have to stay on course towards that, because then if we get that comprehensive coverage and package of the needs of people living with HIV, which are diverse and indeed sometimes very comprehensive, then we get somewhere to assuring the protection of their health. Thank you.
All right. Yes, Kamal.
Dr. Busire, we already had the transition framework and it was showing how much money is needed, what needs to be put in. So they will not start from scratch. They need to go there from it. But Senator Catherine, and you know you've been my leader and you have held my hand all through. Incidentally, for those of you who don't know, even National AIDS Control Council, when it was said, she was there and for everything else. Now, I'm a bit perturbed. We are in Homa Bay, a county with a prevalence of double digit. Not even the governor mentioned about it or asked on how to do with the issues. I think what we are not doing, we're not having our priorities right. One of the things that was done, Senator, you remember, was the passing of the IP Act. Now, there's an amendment coming, if it has not already arrived, to amend the IP Act, which will draw back all gains. And this is because of the SHA, where drugs have been imported from a company with several people who are in government or have the powers from Dubai, and it is coming here, and they will be distributed to the hospitals for it to go on. Now, in that is where now when you are dealing with the issue of the triple threat, it will make the drugs very expensive. It will complicate the matters. In short, I'm just trying to say, and you have mentioned it here, how to do it is by integrating other ministries.
All right.
Now, in your days in school, sex education was taught. Oh, you had already passed. Earlier on, there was sex education that was being taught, and it helped bring down a lot of issues. And the sexual issues were the dangers.
Okay.
And it helped bring down the pregnancies and other issues.
Yeah.
But like you say, the internet and the others are not working.
All right. Thank you, sir. Yes, ma'am. And then take the microphone to the back, and Senator, I'll give you a chance to respond. Let's just take one more, then I'll give you a chance. And then we take the microphone to the back because we're running out of time. Yes.
Okay. Thank you very much. My name is Vivian Ochieng. I work with Homa Bay County. I appreciate the expertise that the panel brings to this discussion. And I have 3 questions today, or rather comments that I'd like some response to. First is on repurposing of funds, of donor funds. We all appreciate that there is a decline in the funds that we're getting as a country. However, are we really talking about how to repurpose these funds and highlight priority areas and maybe more effective efforts that can be done with these funds that we're getting?
First, to say that Governor Wanga is one of the greatest champions of triple threat. And from what Bosire mentioned, among the counties that are recording reductions is Homa Bay, and courtesy of the work she's doing. I come from the region, and she has even mobilized all the women from the region to form something called Nyinam, Daughters of the Lake, and their number 1 issue is to deal with triple threat, and they're doing a good job of that. Now, on the issue of the IP Act, that is the Intellectual Property Act that Kamau is talking about, I have not seen the amendment that you're talking about. But when WTO was operational, we actually held a campaign, a global human rights campaign, that prohibited the patenting of public health goods to ensure that they are not accessible to people. And that's what Kamau is talking about. That if we are going to bring back a law that is going to allow patenting of public health products, then we are going to make it extremely expensive and unreachable to those who need it. We will be vigilant in the Senate. I can promise I will be among those who will mobilize colleagues to ensure that, and we should be advising government that we must not allow an amendment that will make it impossible for government to provide treatment. More so now that government has taken on universal health care seriously. Because if it does, there is no way it can deliver with very, very expensive products. Thank you very much.
Kinyanjui, let me bring Dr. Kinyanjui here. There's a question that Vivian asked about legislation on condom distribution. We'd like to hear your views on that.
So thank you very much. Vivian, you are spot on there that depending on free is, and I think that word free in our guidelines, Dr. Bosire and team, I think we need to rethink about it. Personally, I believe that we should remove it. It's free to the user. It should be, we all need to know that it costs something. So to sustain distribution, whether it's of condoms, whether it's of self-test kit, we need to take affirmative action so that certain classes of test kits or condoms are fairly priced. Because not government, not donors, no one can sustain free distribution or, to meet the needs of the country. There will be about 5 to 10% of the people who don't care how much things cost, they afford. So don't worry about those ones. There are people in the middle here who wants good quality, who like class, but they cannot afford very expensive. And those are the target for subsidized, either the test kits and condoms. And I think AHF in the coming year will be championing redistribution of the AHF branded condom Love and Icon as a subsidized condom in Kenya. We've been given this opportunity to pilot how, to what extent that this will be effective. And I strongly agree with you that we need to, for the self-test kits, it is important to provide subsidize. And the way to subsidize is, and make it sustainable, is for government to intervene by removing taxes.
Okay.
Because, for example, I think male condoms, I don't know the female condoms, but I think both of them will attract almost a 51% in terms of the taxes of the landed cost. So that is the biggest cost driver. So if the government can take back the taxes, the distributors who are socially marketing this can be able to put a price tag that is written, so that there are no advantage. There is no, the end user is not being ripped when they are getting these commodities.
All right. Let me bring in Dr. Besire to talk about the repurposing of funds. Yes, there's a microphone already.
We have to rethink of what is the urgent priority and what can we consolidate and integrate. And those are the discussions that are going on for Homa Bay and for the counties that are here. You are involved in that process of reprioritizing the discussion around the Global Fund Cycle 7, GC7 grant, which takes us up to the end of September, when we'll have the full grant. And even at the county level, we really must ask ourselves, what works? What works? When we know that, for example, in this region that we are, the region of Nyanza, the counties of Siaya, Homa Bay, Migori, and Kisumu, they contributed to 37% of the new HIV infections in the country last year. 37%, almost half. And therefore, our priority here should be in closing the tap and ending the new infections, using our community health promoters, using our assistant chiefs, using our religious leaders, using our fisher folks as champions at the front. And the good thing, these counties are the same ones which have made enormous progress. A county like the one which we are in has reduced its prevalence levels from almost 28% to 15% over the last very few years. All these counties have managed to reduce adolescent pregnancies. They have managed to, SGBV is still an issue in the country, but progress is being made. What we are saying in this discussion, let us not confuse progress with success.
Okay.
We have not yet succeeded, but together we can succeed.
All right.
Thank
you very much. And also, yes.
The idea of legislating for condom, in my view, may just get you in a controversial conversation that is going to divert us from what we are doing. if there were to be a legislation, I would insist we first make girls to access sanitary towels as a priority in education, so that it is the way we give books to girls, we should actually make every girl be able to access sanitary towels, because around lack of access to sanitary towels is the transactional arrangements that are happening that end up with teen pregnancies. And then finally, to Kamau, schools never taught sex. We taught about HIV in a very stigmatized manner. Ukimwi, nizimwi, litakumaliza. You know, I've done an FGD with young people, and the orphans felt very, very stigmatized in the manner in which we actually presented HIV in school. We also taught biology, but we have never taught about the casual consequences of the emotional change of puberty, of attraction to the opposite sex, and the casual consequences, the consequences of casual sex and what happens to the boy and the girl. We don't have that conversation. We are saying it is for parents to do it.
Okay.
The parents were never taught.
All right.
My name is Betty Okero from CSO Network based in Kisumu. I want to raise an issue around the GBV. There is no county in Western Kenya that actually has a budget for GBV. None. And so from that aspect alone, one gets to understand the difficulty in trying to redress GBV. And when we talk about GBV amongst adolescents and young people, we're talking about rape, incest, defilement, sodomy. And they all create their own complications. In the absence of having funding, it means that look at it only from a health perspective, and we need to expand it. And I'm very glad that Senator Muma, you've mentioned something that has been a challenge, the issue around sanitary towels and why we continue to think that we have got to deal with it on a charitable basis. And the fact that we need to have policy that is able to address it, because it is not a 1 day or 1 month event. And I actually get offended when I see us fundraising for sanitary towels for only 1 month and thinking that we have made achievements. If you start understanding that we get girls go onto their monthly periods from the they're 13 years old, they will continue for the next 18 years or more, if they're still in school, back and forth. It tells you the sort of investment that we have to put in place. The second bit is the lack of coordination between our health department and the gender department when it comes to HPV. We consider it a health issue, and only to the extent that we go to a hospital for treatment, you fill in a P3 form, and that is the end. There's counseling, there's no therapy, there's no reintegration, there's no economic component around it. If we start looking at this from a holistic point of view, it becomes a little bit easier to understand, whereas we talk about the police, we also have to talk about the trade department, the one that's dealing with issues around economic empowerment.
Thank you, Betty. Thank you very much for that. There's a microphone back there. There's still a lot going on. Yes. Over there.
Thank you very much. My name is Mohamed Abdi. I work for Nairobi County, also supporting SUPCAM in terms of this issue. Thank you for inviting us this. Maybe just to share a few things that for Nairobi County, what we do is, I have no question, but just a small comment that what we do. Since everybody is talking about policy and guideline, we do follow the policy and guideline of school health policy and guideline from national government, Ministry of Health and Education, which has been signed by both of them, contains the 8 thematic areas: gender, value, and also life skills, wash, nutrition, disease prevention and control, children with disability, and everything. So I think in terms of policy, we are okay, but the problem is implementing. For Nairobi, right now we have mapped all our schools. We mapped them to the PCN program so that we cannot leave. Last year, I had one school of 9 girls who are pregnant. How do we manage? We just refer to our next facility, following up by our nurses in my department, follow up, deliver. After that, what do? There's a lot of stigma because they cannot go back to school again. So we have a policy of return back to school program. We have to do that again through the support of like NSDCC, what they are doing, SGBV, anything that we need to coordinate. So for our program, that's what we are doing for Nairobi. And we cascaded the policy of the national government to contents of Nairobi program. So we are the first county to have a school health manual for the training of the teachers and also health workers, health clubs. So those are the things that I can share with you, and we have enough books for that. That's what we did for Nairobi.
I indicated that this is the business of everybody. It cannot just be siloed for women, neither can it be made just a health issue. Now, not quite in defense of the counties, but just to indicate that GBV is actually a criminal offense. Matters criminal offenses are national government. But you are right, we have gender CECs. And matters GBV are also gender. So the question is, and it comes to what you're saying, what is it that we can do within the county to ensure that GBV does not happen? And earlier on I had said it is everybody's business. It is the CHP's business. Maybe their tools should have an indicator on GBV that is able to bring information to say, in this household, this is happening. It is the chief's business, the sub-chief's business. It is the business of the police. It is the business of the administrator. So how are we functionalizing the intergovernmental relation at the county level for purposes of addressing GBV teen pregnancies and HIV issues? It is something, Governor, you might want to be able to speak to. Recently, the president asked female members of parliament to do some GBV campaign. I picked Nyakach. And when I went there, the first meeting I had, I called everybody. Nyakach elders, the police, they didn't come to guard us. They came to sit and speak. The chiefs, the border, the teen mothers, the teachers, the CHPs, and it was a very rich conversation. So if you bring everybody together, it comes to the question, how do we deal with this? Because even the perpetrator is from the community. This is the one thing we cannot blame State House and say, our kids have been defiled, so Ruto must go. It is the people who must go are your community. They are the ones defiling your children. So we need to be able to wake up and know that it is wrong for a father to defile. Kids are being defiled in houses, in churches, in religious places, in schools. What is TSC doing? Why are they transferring the teacher who defiled a child here to another school? So we need to actually strengthen recognize, number one, these are criminal offenses and they need to be dealt with seriously.
The reason why we have this agenda, this all of society agenda of ending the triple threat, it's a collaboration actually. The government agencies that are leading is NCPD, NSDCC, and the State Department for Gender. And that is why we actually came up with a commitment plan that all these three ministries signed through. Our peers have signed to this book, and we'll be giving you copies of this, and also the CEO of the Council of Governors on behalf of the counties, because we have said let's extend our shilling. If I am going to talk to a team of people like this around issues of HIV, and I'm talking to young people, why shouldn't I use the same platform to talk to them around issues of ending teenage pregnancies, around issues of SGBV? Because, I come here with a vehicle all the way from Nairobi. Myself, I talk about HIV. Dr. Shea comes here, or his people comes here the following day. Same people, same room about adolescent pregnancies. The gender people come here the day after or the week next. Same people, same audience. They want to meet the governor. Even the governor is tired seeing us. And that bad manners that we have at the national has cascaded to the county levels. And that is what we must stop. So for us, in terms of coordination, what we have done, we are supporting quarterly meetings, which we call county multi-sectoral coordination committee meetings. These TWGs that are working, they can be working as technical committees. But once in every quarter, let them meet, report on what they have done, review progress, and plan ahead collectively. So these are there, they are chaired by the county commissioners and co-chaired by the CEC members for health. Next to you is the CC member for health in Homa Bay, and she can attest to this. So these are forums that we are supporting as NSDCC, and we want everybody to come on board so that we can support this quarter, you support next quarter, somebody else supports the other quarter, and all of us, and partners are there, and communities as well. So that is what we must embrace going forward. Thank you.
Countries that have done very well on ending teenage pregnancy and even the triple threat is Thailand. What Thailand did is they came with an act. And in that act, they brought all the ministries, starting with the Minister of Interior, Education, Health, Gender. So 7 ministries were brought together. And the specific funding, what we have, the problem we have in Kenya, we have put this program together with NSDC. But the challenge we have is the problem with the funding. And unless we get specific item for this activity and a specific act that makes sure that, ensures that this thing is implemented from up, down, up, I don't think we will succeed. Because these programs are there, the coordination mechanisms are there at the county level, but they are at the behest of who has the money. So a partner comes, support this quarter, next quarter there's no meeting, there's no reporting. So I think what we need to do is just see how we can, how we can come with a comprehensive mechanisms of how to coordinate triple threat in Kenya. Okay. It can be through an act of parliament, it can be through a coordination mechanism, but that's really what we are lacking.
All right.
Yes, I just want to say my name is Reverend Anisia Karanja. I am a person living with HIV for years. And one thing, we came here so that we can tell you the best practices. One is that I've lived with HIV for 40 years. So if I were to talk, I would talk through the support that I've gotten from the former NAC and now SDCC. I just want to say that Catherine, we've been with her for a very long time, even with tribunal and other things. But the thing is, if you come to my church and you lace up your hand like this, I know you have a story to tell. So when you see us here as communities or people living with HIV, ask us what works, and we will tell you. Are we together?
Okay.
The first thing that should be there, it is condom. Are we together? I'm talking about condom because it will prevent you from getting HIV. It will prevent you from getting STI. It will prevent you from getting teenage pregnancy. Okay? It will prevent you from so many things. So even before you come to ARVs, the first medicine that works is condom.
All right. Thank you.
Okay?
Thank you so much.
Wait.
We're pressed for time.
Another thing that I want to say is this. How many religious leaders are here? When you say they stigmatize, they will speak what they only know. Somebody somewhere was punished by God because he poured his sperms. So Anisia, do you want to change the Bible now that you are HIV positive? Are we together?
Yes.
What is on the ground?
Okay.
Ask the people who are here.
Thank you.
Thank you very much. First, I'd like to introduce myself. My name is David Ogoro from Smart Disability Development Network. And myself, I have an experience of about 20 years in the area of HIV health. So I'd like to also thank the panel for the discussions that we've had in the morning, which have been good and very nourishing to me. I also do see that from the experience, we do have a lot of challenges that we are facing, especially for persons with disability, because we need accessibility, especially for services, accessibility to service for the two persons that I'll say who are affected most, who are the deaf and the blind. Because yes, we do know in the Constitution, yes, well, the Constitution, Article 43, talks about accessibility to health for all. Then we do need, under the Constitution also, Chapter 35.
Okay.
Yes, 35. Yes, we do also need accessibility to information. So
All right.
if you view the two persons of the two cadres of disability that I've talked about, we do need accessibility to information, which is very poor for now.
Okay.
I can say for deaf, we do need sign language interpreters
Yes.
in the places of our health facilities to access health information, especially in the hospitals or the clinic, which is the basic. And then the other thing is confidentiality, which we do lack, because if an interpreter is there, then you have a third party who is not private to the information that I'll be sharing with the doctor, which is personal.
All right.
So it is very easy to break confidentiality for us,
Thank you.
deaf people.
Thank you very much. Thank you.
So I also say in the issues of referral, kindly, the referral pathway, you do see that the referral pathway is not also favorable to us persons with disability.
All right.
Yes.
Thank you. Thank you very much.
In terms of follow-up and referrals, what needs to be done, we need to be able to understand so that when you refer someone, it becomes easier if it is the police or seeking health services. Those are some of the challenges that we have.
Thank you. Thank you very much. Thank you so much
I'd like
for
to
that.
know also what you're doing to be able to support us or to correct the situation.
All right. Thank you very, very much.
Riding on the protocols that have been established already, good afternoon. So these are just a summary of key commitments and emerging action points that we have been able to capture. A comprehensive report will be written and shared with all our stakeholders. So on your screen, the first thing is prioritization of adolescent health as a core development agenda. We need to invest more consistently in the adolescents' health, not as a state project, but as a foundation to development. The next one is adoption of integrated multi-sectoral approaches, linking health, education, justice, and community action to address the triple threat. We also need to enlarge stakeholder engagement, bringing forth all those that have been not on the table for us to be able to make impact. Active youth engagement at all levels of programming, that is from planning to budgeting, to implementation, to monitoring and evaluation. Another key commitment is we need to expand youth-friendly or youth-responsive services and facilities. Already it has been alluded to that even for people with disabilities, we need responsive services for them. If it is waiving services for adolescents as well. Then mobilization of all communities, men, boys, elders, faith, religious leaders, role models to challenge harmful norms and promote positive behavior. Parental engagement has really been emphasized in this. And to be able to avert these vices at the family level, age-appropriate education. Next. Probably the call for action so that we can move with the time. We need to establish inter-county peer learning platforms to share innovations and best practices. We need to jointly resource mobilize. We need to strengthen policies, develop county-level data system, deepen our partnerships. Finally, the last one. This is the call for action today, that we invest consistently in adolescent health, stand united to reject harmful cultural practices, ensure survivors receive justice, invest in youth empowerment programs. Let us all take responsibility. It's everyone's business.
In my view, GBV is a security and safety matter. In fact, my recommendation to the Nancy Baraza task force is that we need Ministry of Internal Security to put funds to GBV to be the chair of a multi-sectoral team that deals with GBV, and on that multi-sectoral team we should have health, we should have education, we should have gender, we should have the judiciary, we should have ODPP in order, in real time.
Okay.
The Minister for Internal Security should be able to tell us, we had 3 defilements in Nyakach last week and we have arrested the people.
All right.
So I have not seen that in this. Please include.
We'll add that. Thank you so much. Let me call, yes,
Please.
just 1 minute.
Yeah, please.
Okay.
The challenge that we have had is actually about the reporting and the data collection mechanism that has been there. These people were reporting using a Mulika system. A Mulika system is where you take a kabambe, you type in, you say, today we had 2 defilements. So and so does. So 5 assistant chiefs send an SMS to the chief. By the time it gets to the chief, maybe the chief's battery is low. The chief is not able to open the message.
Yeah.
The chief cascades upwards to the ACC, from the ACC to the DC. So what you have done, we are supporting the Interior Ministry to come up with an online reporting system where the assistant chief report and the real-time data is captured in Nairobi.
All right.
So from a dashboard, you can actually be able to tell, in Marsabit, we had 10 reported cases of defilement.
Okay.
Then you go to the police and ask the police, what have you done?
Thank
you go to the court. If these cases came to court, what did you do? The health sector, did these people come into care within 72 hours so that we can help them to put them on PEP, post-exposure prophylaxis? So we are working with them also on that.
Thank you very much.